Welcome, welcome. Thank you for being here. On behalf of NHF, welcome to Coexisting Women's Health Conditions. My name is Jasmine Palderai, and I am an education specialist here at NHF and also the session manager here. I am very excited for this session. So often I've been getting questions of, well, how does any other condition I have affect my bleeding disorder? Endometriosis, PCOS. When do I reach out for help for a second diagnosis because I think I might have something beyond my bleeding disorder? We're answering all of that and more. So I'd love to welcome to the stage Dr. Woods.
Good morning, everyone. I'm Kalinda Woods. I am an obstetrician gynecologist at Emory University in Atlanta, and I have a special interest actually in women and girls with bleeding disorders. So between Emory University, Children's Healthcare of Atlanta, we have sort of a collaboration, and we have bleeding disorders clinics where we actually see women and girls on the adult and pediatric side with bleeding disorders, and of course, whatever gynecologic needs they may have. So today we're going to be discussing coexisting women's health conditions. As we all know, bleeding disorders are one reason why people may have abnormal uterine bleeding, pelvic pain, but there's a whole host of gynecologic issues and concerns that can complicate that. And we'll kind of march through that this morning. No disclosures. So abnormal uterine bleeding, the differential diagnosis. The differential diagnosis, as you guys probably know, are all the potential reasons why an individual may have a particular condition. There are many, many reasons why women can have abnormal uterine bleeding, but for purposes of today's talk, we'll focus on the ones I listed above. And I'm going to add a little bit at the end about endometriosis. I know a lot of women are, that's been in the forefront lately in the media and in lots of different modalities. So we'll touch on that and answer any questions you guys have regarding endometriosis specifically at the end. So we'll talk about anovulatory bleeding. We'll talk about PCOS, thyroid disease, pregnancy, cervicitis, which is cervical inflammation. And we'll also go through structural issues, things like fibroids and polyps, which can certainly complicate bleeding disorders. So HPO, that is the hypothalamic pituitary ovarian axis. Basically, it's the brain-ovary-uterus connection. And sometimes it takes several months or years once a woman starts her period for this system to sort of organize itself. So actually one of the more common causes of abnormal bleeding or heavy bleeding, especially in people with bleeding disorders, is that that process is just not yet mature. So within about 2 years of somebody beginning their menses, we expect that process will be complete. But anytime from the onset of menstrual bleeding to 2 years after, we can almost expect that people will have some degree of very disorganized, irregular bleeding. So just for some definitions, abnormal uterine bleeding is defined as bleeding for longer than 7 days, bleeding heavily, meaning saturating more than one pad or tampon per hour, or bleeding that occurs at irregular intervals. Any one of those 3 parameters is enough for us to investigate and treat. During the first 12 to 18 months, like we talked about, after the onset of menstruation, immaturity of that brain-ovary-uterus connection can often be an etiology or a reason for having that type of disordered bleeding. Anovulation is the most common cause of abnormal uterine bleeding, and this is just irregular ovulation during the early adolescence. By the 3rd year after menarche, which is the onset of the periods, about 75% of menstrual cycles are typical, meaning between 21 to 34 days between periods, regardless of when the menses began, okay? So how do we treat this? So often we'll have moms come to us with their pediatric daughters very concerned about starting medications and doing hormonal modalities to regulate bleeding. So the first step is always watchful waiting, because remember, as we discussed, this is usually self-limited, meaning it's going to resolve itself with just the tincture of time. So watchful waiting is always appropriate in the appropriately counseled family. If a patient is not bleeding to anemia and the symptoms are tolerable, we can just sort of wait for that brain-over-uterus connection to mature. Of course, hormonal therapy, very appropriate for most girls and women of all ages, and people who are having bleeding that's disruptive to their school life, to their family life, to their work life. That is an appropriate thing to pursue. Lots of different ways to do that, and we'll talk through some of those as we advance. Of course, with women with bleeding disorders and girls with bleeding disorders, we have the antifibrinolytics medications like tranexamic acid and Amicar, which actually work on the bleeding profile aspect of things as opposed to a hormonal approach. So now we're going to talk a little bit about the polycystic ovary syndrome, which is actually very, very common and often underdiagnosed. So what is this? So PCOS basically is a little bit misnamed, we think, in gynecology. It could have a better name. When you hear polycystic ovary syndrome, most people, what comes to mind is like big ovary cysts, pelvic pain, like something functionally wrong with the ovaries, and that's actually not what this is. So this is disorganized bleeding due to a deficiency of progesterone. So the one thing I want you all to remember about the hormone progesterone only occurs at the moment somebody ovulates. That's when you get a big progesterone surge. So if somebody is not ovulating in a very cyclic and rhythmic way, their progesterone levels are going to be lower. The lining of the uterus is very confused. It doesn't know if it's in a build-up or a breakdown phase, and you get very random disordered bleeding. And that's the nature of the polycystic ovary syndrome. It's also associated with something we call hyperandrogenism, basically elevated male-type hormones, things like testosterone, which is actually structurally, as a molecule, the opposite sort of progesterone. So if the ovary is not ovulating cyclically and not making enough progesterone, it defaults to testosterone production. And many women with PCOS, not all, but many women with PCOS will notice things like hirsutism, which is male pattern hair growth on the face and chest, acne, and male pattern hair loss as well. So PCOS is also associated with the metabolic syndrome, which many of you have probably heard of, insulin resistance, central obesity, acanthosis, which is kind of darkening of the skin folds of the neck. For some metabolic reason, and the exact mechanism honestly is not yet understood, but these syndromes sort of go hand in hand. So with PCOS, our treatment goals are basically, in gynecology, our number one treatment goal, we are always thinking about the endometrium, which is the lining of the uterus. Now, remember we talked about progesterone surges at ovulation. Progesterone keeps the lining of the uterus very stable, very healthy. So over one's reproductive lifetime, if you're not ovulating as rhythmically as 12 times a year, then you have a net deficiency of progesterone. You can think of it that way. So the other predominant hormone in the cycle, estrogen, is allowed to rise, essentially. So you want estrogen and progesterone to rise and fall together always. Whenever there's too much estrogen over decades and not enough progesterone, that's actually a risk factor for things like uterine polyps and uterine cancer, has that pathophysiology behind it. So one of our goals when we're treating polycystic ovary syndrome is to actually supplement progesterone to kind of mimic a more typical hormonal environment for the lining of the uterus. That's very important. Most patients with polycystic ovary syndrome have concerns about pregnancy and fertility. So remember, this is a disorder of anovulation, infrequent ovulation. So the average individual might have 12 opportunities per year to conceive when they're trying to get pregnant, 12 ovulations, right? Somebody with PCOS may have 2 or 6 or 1 or maybe none in a given year. So often we'll use medicines to induce ovulation to help people conceive when they're ready and when the time is right in their life. We do have those things in gynecology. So I always counsel patients whenever we make this diagnosis, we don't want them to be overly concerned about that aspect of things because we can cause ovulation. The eggs are there, the potential is there. It's just a matter of stimulating the ovary enough to release its eggs. And then of course, bleeding control, obviously for our girls and women with bleeding disorders. You know, the bleeding that's associated with polycystic ovary syndrome is very disordered. So often patients will come in and say, hey, I had this really heavy period. It lasted like 2 weeks. I was soiling and staining clothing. And then I had nothing for 6 weeks. And then I had spotting for 3 days. And then I had nothing for a month. And then I had a period. And then I had another period. And then I had nothing for 3 months. So this is anovulatory bleeding. This is a pattern issue. So these patients can often become, even without bleeding disorders, very, very profoundly anemic, just because of the heavy disorder bleeding that they do have. So bleeding control is a major goal for treating polycystic ovary syndrome, and there's a number of ways to achieve that. So if you were to look at an ultrasound of somebody who has PCOS, this is a transvaginal ultrasound of the ovary, they might look like this, they might not. So I just put this ultrasound image here to illustrate the point that this is not a radiographic diagnosis. So often people come in and say, oh, they thought I had PCOS, but I had a normal ultrasound, so I just can't have that. and that's just not true. Sometimes the ovaries may appear this way in polycystic ovary syndrome, but not always. This is certainly not diagnostic. So that's just something to bear in mind. Here's a slide that just sort of illustrates all the symptoms that some people can experience with PCOS, and I actually can't see it very well from here, to be honest with you. So you guys can kind of look at that. But remember, the mainstay of this is anovulatory bleeding, disordered bleeding, and our main goal is to protect the lining of the uterus. We want to replace progesterone, and that's going to actually decrease the risk for uterine cancer, which is actually the commonest of all the pelvic cancers in the US. We want to control the bleeding pattern for convenience and avoiding anemia. We want to induce ovulation in those who are attempting pregnancy. And we want to manage the androgenic symptoms, the male type hormone symptoms like controlling acne and unwanted hair growth. So I'm going to touch a little bit on thyroid disease. So thyroid disease is actually very common. Thyroid can be underactive, thyroid can be overactive, and both of those entities can cause very disordered, disruptive bleeding. And often in women who already have a known diagnosis of a bleeding disorder, sometimes when bleeding gets a little bit irregular, people assume that, oh, you have a bleeding disorder, like let's just increase your TXA and try to infuse a little bit, and these things aren't investigated. So we want to always bear in mind that whenever somebody has a change in whatever their typical pattern is, we need to be thinking about other medical problems that can also contribute to abnormal urine bleeding, and thyroid disease is certainly one of those. Thyroid disease is actually pretty easy to diagnose. It's a simple blood test. The thyroid stimulating hormone typically is what we look for. When the thyroid stimulating hormone is very high, that means the brain is working very hard to make the thyroid respond. That's a sign of actually hypothyroidism. It's a counterintuitive kind of inverse relationship. When the thyroid stimulating hormone is very low or undetectable, that means that the thyroid gland is very overactive. That's a sign of hyperthyroidism. So just a very easy blood test that any primary care doctor, internist, pediatrician can do to help to exclude that. And these diseases are quite, simple to treat medically. So TSH, the thyroid stimulating hormone, comes from the same area of the brain as the FSH and the LH, would stimulate the ovary. And this is why sometimes those pathways can get crossed and things can interfere if the TSH is overactive or underactive. Like we talked about, it's a simple blood test and it's straightforward to treat with medicines, and often just simply adding a pill a day or every other day or however the patient needs to be treated is enough to eliminate the abnormal uterine bleeding. So that's always something to think about. So I'll talk a little now about pregnancy-related bleeding. Pregnancy-related bleeding is its own lecture. So I'm going to kind of power through this a little bit. And of course, if you guys have questions at the end, we can always go through that in greater detail. Excuse me. The most common cause of pregnancy-related bleeding in the first trimester is something called subchorionic hemorrhage. And basically, that just means that literally when the embryo implanted into the wall of the uterus, there was a little bleeding that happened behind the sac. And sometimes that sort of trickles out early in pregnancy. Of course, in somebody with a bleeding disorder who has a harder time clotting, that's going to be a little more profound and heavy and might look more concerning. But this is typically something that we manage expectantly. There's no treatment for that. We just kind of counsel people through it and do serial ultrasounds to make sure that it resolves and that the fetus is looking okay. Another common cause of early pregnancy bleeding is miscarriage, also known as failed early pregnancy or spontaneous abortion. Very, very common, unfortunately. About 1 in 5, we think, pregnancies end in miscarriage in the first trimester. And the most common reason for miscarriage is chromosomal disorganization. So the sperm and the egg came together, that material didn't organize correctly, and either it doesn't develop or an individual starts to cramp and bleed. And that's usually the way that ends. Ectopic pregnancy means the conception occurred. However, the embryo did not make it into the uterus. So all conception occurs in the fallopian tube, actually. That's where the sperm and the egg always come together. And typically that little cellular process migrates down the tube and implants in the uterus and hopefully grows. Sometimes it gets stuck in the tube, and that is what we call an ectopic pregnancy. This obviously is not consistent with healthy embryo development. Is very dangerous for women. So this definitely needs to be treated and identified early. The most common symptom of ectopic pregnancy actually is first trimester bleeding. So anybody with a positive pregnancy test who's spotting or bleeding in any way definitely needs to be evaluated and ruled out for ectopic pregnancy. And then later in pregnancy, once the pregnancy develops, Placental abnormalities, preterm labor can be third trimester complications of pregnancy that can present with bleeding. And we'll get into that a little bit. So like we talked about, subchorionic bleeding, usually self-limited. We manage that expectantly just with serial ultrasound typically. So you can see the ultrasound image there with that little out pocket pouching of dark fluid behind the embryo. That is a subchorionic bleed. So anything that looks black on ultrasound is fluid. So the fluid kind of on the top of the image is the amniotic fluid, and that little kind of bean-shaped being is the fetus. And then behind the fetus, you see another sac of fluid that is not typical. We should not see that on ultrasound, but that is a subchorionic bleed. Usually gets reabsorbed and rethaws. Spontaneous abortion, which is loss of pregnancy prior to 20 weeks. 90% of these happen early in the first trimester prior to 8 weeks. This complicates, like we talked about, 1 in 5, up to 20% of all pregnancies, unfortunately. Aneuploidy, which is abnormal chromosomes, is the most common cause of spontaneous abortion. And we manage this based on the symptoms and the desires of the patient. Sometimes we can manage this expectantly. The patient will pass the pregnancy tissue. Sometimes people want the procedure to hasten the process. We can also give medicines to hasten that process if patients desire. Ectopic pregnancy, like we talked about, vaginal bleeding, most common presenting complaint. It's usually in the tube, but it can also be on the ovary. It can be really anywhere in the abdomen, on the cervix. And these are treated with medicine or with surgery. And that's just a little picture of that. All the different places an ectopic can be. And I've seen them all those places. Okay, so with pregnancy-related bleeding, the most important thing is obtaining ultrasound to figure out where the fetus is developing. That's key. And we always want to check pregnancy hormone levels. If you have a typically developing pregnancy in the first trimester, that pregnancy hormone level, we call that the HCG, the human chorionic gonadotropin, that's going to double about every 48 hours. So if somebody has an HCG level that's plateaued or dropping or not doubling, then that's a sign that this is not a normal intrauterine pregnancy, and we should probably proceed with some sort of treatment based on whatever the diagnosis is. Bleeding in the second and the third trimester have much more broader differentials, meaning many more entities and problems that can cause those things. Obviously, bleeding disorders will exacerbate all of these issues, so we want to identify these very early. But some of those things are things like preterm labor, cervical insufficiency, placental abruption, where the placenta actually starts to separate from the uterus too early, and placenta previa, where the placenta is actually covering the opening to the cervix. So all of these things can cause profound bleeding actually in pregnancy, and certainly worsened in women and girls with bleeding disorders. So just to say a few words about cervicitis, another cause of GYN bleeding that we often see. This is inflammation of the cervix. So this is commonly caused by STIs, actually sexually transmitted infections. So sometimes people will come in like, you know, I think there's like not a misconception, but there's a thought in like general in the community that if you have like a pelvic infection that's transmitted sexually, you're going to have some sort of burning or some discharge or some odor or some very obvious symptom. And in women, that's not often the case. Like gonorrhea and chlamydia, for example, are usually asymptomatic in women. And one of the first signs that we often see is abnormal bleeding or spotting from inflammation of the cervix, actually. So that's always something that we want to keep in the back of our minds. Always bear in mind the average age of first sex in this country is 17.2 years old. So oftentimes in our pediatric clinics, we have girls with bleeding disorders who come in with, you know, strange bleeding between periods and things like that. We always have to bear in the back of our minds, we need to inquire about sexual activity so that we can appropriately diagnose and treat whenever necessary. Bleeding after sex, postcoital bleeding is sometimes associated with vaginal and spotting, sometimes associated with vaginal discharge, all symptoms of cervicitis or endometritis, which is inflammation actually of the lining of the uterus. And all of these entities can give us very, very profound abnormal bleeding. Chlamydia, gonorrhea, and trichomonas are the most common infections in the pelvis that can lead to these types of presentations. And this is a very simple lab test to do. It's done with a swab. It can also be collected in urine. If somebody does not want a pelvic exam or you don't have the capability to perform a pelvic exam, you can always give a urine sample. We can get the same information. That's what kind of things may look like on exam when people come in with spotting after sex, bleeding between periods. And this is actually cervical inflammation. Typically, the cervix looks like the inside of somebody's mouth, like it's very pink and pale. And when the cervix is very beefy and red, obviously it's very friable, so very prone to bleeding. And that's what things can look like on exam. So how we treat this, obviously we want to treat the underlying infection first. Counseling, condoms, contraception, whatever the patient may need. Partners do need to be treated, and I think it varies based on state whether or not prescribers can actually give partner expedited therapy, but that's sometimes something that can be done. You can just give a patient a prescription for she and her partner. They should abstain for 2 weeks after they've been treated, and they should consider a test of cure, meaning we repeat the test in 30 days to make sure that things have resolved. And whenever we're diagnosing any sexually transmitted pelvic infection, we always want to screen for all the ones we can screen for, just to make sure we're covering all of our bases. And we're going to talk now about fibroids and polyps, structural problems that can actually contribute to abnormal bleeding. So what are fibroids? Uterine fibroids are actually non-cancerous growths of the uterus that often appear during people's childbearing years. So these are very, very common. We think about probably 80% of all women have fibroids in the uterus, and they can be any size. They can be as small as a pinhead. They can be as large as my head. And how they present depends completely on where in the uterus they're located and how large they are. As most women with fibroids do not know they have them. They're asymptomatic. And it's often a diagnosis we make incidentally, like somebody's having an ultrasound because they're pregnant. We're like, oh, you have, a couple fibroids in there, or somebody's having an appendectomy. I've been called into the OR for intraoperative consultations, often by my surgical colleagues. They'll be doing some really complicated, bowel surgery, and the patient will have like a little fibroid sitting on the uterus, and everybody wants to know like what that is and what we need to do about it. But the key thing with fibroids is that they are often asymptomatic, but when they are symptomatic, women, especially women with bleeding disorders, can get very profound bleeding from fibroids. So there are many different ways to treat them. They're also called leiomyomas or myomas. Most are asymptomatic, like we talked about. They commonly become symptomatic in people's 30s and 40s. And we think that's because they're slowly growing, probably from the time people start having menses. They're estrogen-dependent masses, so they grow from the estrogens people make when they ovulate, essentially. So these are not often problems for postmenopausal women. So once people have gone through the menopausal transition, they're no longer surging those hormones monthly. So fibroids tend to become completely asymptomatic once people become postmenopausal. They're not likely to be symptomatic in adolescence, although I have had maybe 2 or 3 in the past 10 years or so, younger women that did have symptomatic fibroids. So always something that we want to be thinking about. So women who have symptoms, the most common signs and symptoms, heavy menstrual bleeding. So obviously this is also a common sign or symptom in women with bleeding disorders. So often this might get missed, right? Oh, you have, a factor 7 deficiency. So that's why you have heavy periods. Let's just treat that. But it's important for us to remember that we need to work the whole thing up because fibroids are very, very common, like we mentioned, 80%. Menstrual periods lasting more than a week, pelvic pressure and pain, frequent urination, difficulty emptying the bladder. So somebody uses the bathroom, they get up to go about their day, and they have to go right back, and they feel like they have to. I see head nods, so somebody relates to that out there. Constipation, backache, leg pains, all symptoms of uterine fibroids. And they can be kind of any place within the uterus. They can be on the surface, we call those subserosal. They can be in the wall of the uterus, intramural. They can be in the lining, in the endometrium. We call those submucosal. Submucosal fibroids can be teeny tiny, but those are the ones that tend to cause the most dramatic bleeding because of where they're located. So you can see that kind of triangular shape inside the lining of the uterus, that's the endometrium. That's the part that's responsive, that's hormonally changing, that's building and shedding. So if you have something that's space occupying, basically a mass, in that area, you can get very, very dramatic bleeding, even when the fibroids are tiny. So this is an example of what I was just mentioning. This is a submucosal, or sometimes we call them cavitary, in the cavity of the uterus, fibroids. Just to orient you, this is also the area where an embryo would be, right? Like if somebody were pregnant, this is where the baby would be. So this is actually a hysteroscopic image looking through the cervix with the camera. Just like when people go to GI, they have their colonoscopy, they put the camera in the rectum. We put the camera through the vagina, through the cervix, into the endometrium. And obviously here we found this is probably maybe 8 millimeters, not even a centimeter. It looks huge, but that space, the endometrium, is not very large. So you can imagine this is occupying that entire space. So every time somebody has a menses, all that tissue is being slothed, and this is going to be very disruptive, right? But we could take that out. So this is how they look. This is probably one of the bigger ones I've ever seen. So that's like 40-something fibroids, and this is somebody who wanted to keep her uterus intact because she wanted to become pregnant in the future. So we did a myomectomy, which is an open surgery, removal of the tumors, and kind of restoring her anatomy. And she actually did quite well. She had von Willebrand disease and got all of the pre-op and post-op prophylactic medicine. So she did not actually have a huge blood loss, if you can imagine, with this. And she did great. Polyps, what are those? So uterine polyps are growths that are attached to the inner wall of the uterus that extend into the uterine cavity. So not fibroids. Fibroids, think of those as like muscle walls. They're like solid masses. Polyps are more like soft, kind of sessile tissue, just like you can get nasal polyps, you can get ear canal polyps, colon polyps. You can get a polyp in the lining of the uterus, believe it or not, fairly common. We call these endometrial polyps. They are also estrogen dependent, just like fibroids are, so often a problem in people who are menstruating. Estrogen plays a role in causing the endometrium to thicken each month, and it appears to be linked to the growth of the polyps. That's what they look like. This is another hysteroscopic image, and I think I have a before and after up there. So one of them, you'll see something space occupying. I think it's the top right. And then on the bottom is after we resected the polyp and sort of restored that kind of concave cavitary appearance of the lining of the uterus. And this patient also did quite well. All right. So initially, when we see patients with abnormal uterine bleeding, history is very important for us as physicians and people who take care of patients, clinicians. We're going to ask you a ton of questions, right? And that kind of helps us hone in on the diagnosis, because all these different entities I just mentioned often have associated symptoms, right? So somebody comes in with, weird bleeding, and they also have been losing weight and feeling really warm. That might make me start thinking about like a thyroid or endocrine type issue. Somebody comes in with unusual bleeding and they're very uncomfortable in their pelvis and they're very constipated and they feel really bloated. That might lead me toward thinking about something structural. So how we sort of approach patients is all about the history, especially actually in women with bleeding disorders who often, it may take longer to make these diagnoses because people are assuming in many cases that it's just a bleeding disorder. But once we've corrected for that, we've replaced factor, we've given antifibrinolytic support, yet and still people are having problems. It's incumbent upon us as providers and physicians to investigate and establish the issue. Let me talk a little bit about endometriosis, because I don't think I have a slide specifically for endometriosis on the screen. So endometriosis is a different entity altogether, not usually characterized by heavy bleeding. It's typically characterized by severe pain. Usually the severe pain with menses is onset at menarche. So these are girls who are often missing days of school. They're having to leave work early because they are debilitated by the pain that occurs when they have their periods. What's happening with endometriosis, we don't really know the true pathophysiology, but the theory is that every time somebody has a period, obviously the endometrium thickens, like we talked about, that tissue sloughs, comes out the vagina, you can see it. The theory is that a little bit of that tissue goes the other way, right? Out the fallopian tubes, into the abdomen, where it can implant. We think this probably happens to everybody in every menstrual cycle, but for some people, for some reason that we do not understand, that tissue is very immunogenic. It kind of incites reactions in these people. So not only does it implant on the bowel, on the pelvic sidewall, on the bladder, wherever it lands, it's very dynamic. It still behaves as though it's inside the uterus, right? So now you have this endometrial tissue that's outside the endometrium. It's in wherever it is in the abdomen. Every time somebody ovulates, remember that they surge their hormones. That tissue proliferates wherever it is on the bowel. They don't conceive, the hormones crash, the tissue bleeds internally. So now every 28 days or 29 days, however long the natural cycle is, they have debilitating pain and often other symptoms based on wherever the tissue landed. Often they'll have, trouble with defecating. They'll have painful urination during their period. They'll have nausea and vomiting because it's on the small bowel. I don't have any laparoscopic images. I wish I did, to show you some stages of endometriosis, but some of these patients, when you look in their abdomen and pelvis with the camera, can actually almost look like cancer patients. That's how distorted the anatomy is. Like, it can be very, very profound. And how it appears sonographically and on imaging and directly does not correlate with the level of pain that people have. Sometimes we'll be doing a C-section for, like, you know, obviously a delivery, and we'll be like, oh my goodness, she's got endometriosis all over the place. And the patient's like, yeah, my periods are fine. And then we'll have a patient with like severe pelvic pain, and we do a laparoscope, and they have like one little pouch of endometriosis in one small area, and they can't work once a month. So it is a very not well understood entity, but obviously very debilitating and definitely worthy of investigation and, you know, counseling and treatment. How we like to treat endometriosis is by ovary suppression. Actually, this is the ovulatory problem. So the problem happens again and again every time somebody ovulates. So the mainstay of treatment of endometriosis is suppressing the ovary, stopping ovulation. How do we do that? Lots of different ways to do that. That's how birth control pills work. That's how the patch works. That's how the NuvaRing works. They all stop ovulation from happening. We basically turned off the hormonal switch that's driving this tissue to proliferate. And that's why people's pain improves and their quality of life improves. There is some benefit also to surgical resection. Like if you have endometriosis implants, we call them, in the abdomen, we take those out. But the problem is, if this is a reproductive age individual, she's going to ovulate again and again and again and again. So that tissue can certainly return. So we want to definitely suppress ovaries in people with endometriosis. Sometimes the bleeding that they have internally with endometriosis can be very profound, especially if there's a concomitant bleeding disorder. Endometriosis on the ovary is actually called an endometrioma, and they can be huge. The biggest one I saw was 17 centimeters, and they can rupture. And obviously, if somebody has endometriosis on their ovary and the bleeding disorder and a rupture, that can be a catastrophic hemorrhage. So this is definitely something we want to diagnose early. So complaints of pelvic pain, painful periods in girls, adolescents should never be ignored. That should always be investigated. Most gynecologists around the country are very willing to see kids. I see kids in my office all the time. So if the pediatrician is not addressing the issue, then that's definitely something that we want to see patients for, because that is something we can treat early and save people many, many years of discomfort and abnormal bleeding. So just a word about that. One word about postmenopausal bleeding. I didn't put that slide on there. It was postmenopausal bleeding is not normal ever. And that's always something that needs to be worked up. So menopause we define as no period for 1 year. It is a clinical diagnosis. It's something that the patient tells me. I never tell somebody she's in menopause. When you tell me you haven't had a period for a year, that's when we say, check, you're done, you're a menopausal person. And going forward, that person should never, ever bleed again. If they do, that needs to be worked up. The most common cause of postmenopausal bleeding is actually something called atrophy. So the lining of the uterus has become so scant, especially in women with bleeding disorders, that the edges of the endometrium are actually abutting each other, and you can get some bleeding just from that process alone. And that's a benign issue. We typically treat it with a little estrogen cream for several weeks, and that resolves. Other causes of postmenopausal bleeding: uterine polyps, uterine cancer. That is the presenting symptom for uterine cancer. So whenever somebody has postmenopausal bleeding, we have to biopsy the lining of the uterus to prove that that is not what that is. But that is never something that should be ignored. So sometimes we'll have women, postmenopausal patients with bleeding disorders come in like, oh yeah, I spot every now and then, but I have von Willebrand disease, so that's, I always had weird bleeding. No. After menopause, the uterus should never, ever, ever bleed, ever at all, ever. So that's always something that we want to work out. Okay. All right, there's some references for you all, and I'm happy to take any questions. If you guys have any questions about anything we talked about or anything we didn't talk about, I'm happy to address it right now. Yes. That's the one. I'm glad you asked that. That's a wonderful question. So no, unfortunately, and that's the problem with endometriosis. So the gold standard for diagnosing endometriosis is laparoscopy, direct visualization. It will not be picked up on an ultrasound. It will not be picked up on an MRI. It will not be picked up on a CAT scan. Sometimes if you have an endometrioma, like that big endometriosis cyst on an ovary, we call them chocolate cysts, because literally when we open the cyst, it looks like Hershey's chocolate. I don't know who came up with that, but that's exactly what the fluid looks like. That's pathognomonic, or diagnostic for endometriosis, but there's no, unless you have an endometrioma, which you may not have, you may have it on your bladder or on your sidewall, or endometrioma we can definitely see on ultrasound and CAT scan and MRI, but other types of endometriosis we cannot see. And sometimes in our younger patients, what we'll do, because we cannot see that directly, if they have that story, I'm throwing up every month, I'm bent over in half, I can't get out of bed, I miss 2 days of school every month, I'm crying, we just treat. Like we just say, okay, maybe it's just dysmenorrhea, which is just painful periods in a young person because their canal is really small, their uterus contracts really strongly and all that kind of thing. We just suppress them. We just say, hey, take some medicine, we'll get you through this. But the gold standard technically is laparoscopy surgery. Mm-hmm. Other questions? Yes.
Do issues of anemia become less of a concern as a woman approaches menopause?
Yes. Well, kind of. Sort of. So the time before menopause, we call the perimenopause, right? And perimenopause can start up to 6 years before somebody actually stops having periods. So the average age for menopause is 51 in the US, 51 and a half, something like that. So the perimenopause means the ovary is starting to rev down, right? It's running out of eggs. So it's ovulating not as rhythmically. I'm an ovary. This is my ovary motion. It's ovulating not as rhythmically as it once did. It's kind of like, no. Yes, maybe. So the hormonal consequence of that is crazy bleeding. So often just the perimenopause is associated with very erratic bleeding, almost like when the early part, when the menarche that we talked about, when the HPO axis is not yet mature, things are not organized yet. It's the same thing in reverse, essentially. So sometimes people can get very anemic right before they go through the transition, meaning they stop altogether. So once you stop having uterine bleeding, of course, there's many reasons to be anemic, but once you stop having uterine bleeding, we can presume that if somebody has persistent anemia, it needs a different workup, right? Because the menstrual losses are done at menopause.
I have another question.
Mm-hmm.
What about, I almost want to say, I guess the term would be structural changes in your uterus after childbirth.
Yes.
Something like, what's it called? Like a prolapse or something?
Mm-hmm.
Like how does, can you give a little bit of
Sure, we can talk about that. Yeah. Yes. So the structural changes that occur to not just the uterus, but to the whole abdominal wall. And when you think about the abdominal wall and the musculature, the connective tissue, that kind of is your core, what we call the core, yoga, Pilates, those muscles curve around the pelvis and kind of attach at the sacrum. So the pelvic floor is what we think about when we think about pregnancy and childbirth and delivery. That's what gets disrupted when somebody is pregnant. And it's really not even the vaginal birth that does that. It's just the fact that somebody was pregnant for 36 to 40 weeks, and all that musculature was attenuated, right? All that tissue got stretched out. It's just like a scrunchie. Like the more you do this, the less bounce back it has. So the more pregnancy events somebody has, the less kind of like strength that tissue actually has. And one of the consequences of that is as people get into, later reproductive life, post-menopause, you can have something called pelvic organ prolapse. And basically any organ in the pelvic can prolapse. Prolapse just means that the organ is almost like a hernia. The organ has left this anatomic space and it's in some other space. So the bladder can prolapse, and sometimes we can see the bladder coming into the vagina. We can see the rectum coming up into the vagina. We can see the uterus and the cervix coming out, like towards you and me, like if we were doing a pelvic exam. Sometimes I'll go do a pelvic exam on somebody who's 80, she's having some sort of issue, and there's her uterus right there. I mean, that's called a complete pelvic organ prolapse, or procedentia is the older term for that. Sometimes that can be associated with spotting in postmenopause because the tissue is actually rubbing against some garment or undergarment or fabric, and you actually have abrasions and, things of that, ulcerations and things of that nature. So this is where our pelvic exam comes into play. Like any complaint of bleeding after menopause or discomfort needs to be evaluated. Prolapse sometimes is asymptomatic. Like sometimes we'll identify it on exam. Nobody has symptoms. They don't, it's not dangerous. So if people aren't symptomatic, we don't necessarily need to treat that. Some people have symptoms like incontinence or pelvic fullness, sometimes even like fecal incontinence, losing air from the rectum. unable to control it, all of those things are treatable, usually with surgeries. They have actually quite a few minimally invasive techniques these days for prolapse symptoms, like Botox in the bladder works really well. Rectal manometry, where they do kind of like ultrasound stimulation of the anal sphincter, but these are all like problems usually that happen in people who have been pregnant. Not always, though. Sometimes obesity is a risk factor for pelvic organ prolapse. Smokers have a higher incidence of pelvic organ prolapse because we think the tissue strength and tissue tensility is not quite there. But yes, that is definitely something that we often see in GYN. Other questions?
I think I heard some mention earlier of like progesterone causes ovulation. So for
Ovulation causes progesterone.
okay. And so a lot of the issues are treated by kind of suppressing that. So if you're on like birth control or some kind of hormonal treatment from puberty to menopause, does that mean that you're at a greater risk for certain things, or that you haven't been getting the same hormonal rhythm that another person would have?
That's actually my favorite question. Thank you for that. Love that question. So you would think so, right? But actually the opposite is true. So let's think about this from like an evolutionary biology perspective, right? So 70,000 years ago in nature, all of us XX females would have like 19 kids, right? We would never have any periods. Why do we never have periods? We're always pregnant or lactating, right? So you're 15 years old, you get partnered up with a caveman, you have a baby, you lactate for 5 years. There's no Similac, there's no Enfamil. You have to hunt and gather. So you're going to nurse your baby for 5 years until they're old enough to hunt and gather. And then what happens? Boom, you're pregnant again. 40 weeks, birth the baby, lactate 5 years, hunt and gather, pregnant. Feed the baby, 5 years, you know what I'm saying? So a period, from a biology perspective, is a natural consequence of a failed ovulation, right? So you ovulated, you didn't conceive, therefore all this dramatic shedding, hormonal flux, bleeding happened. In nature, that is not how we're really designed to be. You're always supposed to be a little bit pregnant, right? And that's how they design contraceptives, to simulate hormonally your early pregnancy environment, right? So we have fooled your brain into thinking you already conceived, so you don't need to keep kicking out eggs. And that's how contraceptives were designed. That's how they work. That actually is protective. So lots of ovulations in one's lifetime is actually a risk factor for ovary cancer. So the classic like medical student test question for ovarian cancer is like a 70-year-old nun comes in with abdominal fullness and pelvic pain. Why did they tell you she's a nun? Well, we can presume she's never needed a contraceptive. She's never been pregnant, and she's old, right? So this is somebody who ovulated a lot. That's what they're trying to tell you in the test question. And our medical student mind goes to, okay, she's got ovarian cancer, and then we answer our questions accordingly. So lots of ovulations is actually a risk factor for ovarian cancer. No, not enough progesterone is a risk factor for uterine cancer, like we talked about. So being on contraceptives is very safe, super effective, and actually the more physiologic condition than ovulating a lot in your lifetime and not being pregnant all the time. Okay. Oh, thank you. I love that. Yeah. It's interesting. Like modern people, the way we live is not how we lived 70,000 years ago, of course. And we have, physiology consequently from that process. So it's interesting to think about it that way. But yeah, pregnancy is protective, and contraceptives are kind of simulating that hormonal situation, keeping your ovary kind of quiescent for longer periods of time. Okay. Any other questions for me? Yes, ma'am.
So I'm still newer in the bleeding disorders community. We have a 5-year-old and no family history. And now all of the symptoms that I had make sense.
Yes.
But where do I start for my 2 children that are females?
Yes.
they're 23 and 26. So now think that it's time for them to start
Oh, yeah.
intersecting with maybe a women's portion of our HTC. And where should we start and what questions should they be asking? Because they had so many of those symptoms that I had that I didn't understand.
Yes. So at 23 and 26, they definitely should be touching base with their GYN, so general gynecology. And given the family history, that's part of the information that we obtain when we have a new patient that we interview. That's one of the questions we always ask. Any chronic illnesses running your family? Of course, in gynecology, the menstrual history is a whole subset of the history we collect when we're interviewing a new patient. When did you get your first period? How many days do they last? How many tampons or pads are you using in the heaviest days? Is your timing, how's your period interval? Like, we are going to tease out, even if they never said, my mom has a bleeding disorder, we would tease out that information by the history gathering. So really, honestly, 21 is probably the latest anybody needs to see a gynecologist. That's when we start Pap screening. So the Pap smear, not to get on Pap smears too much, but the Pap test is a screening test for cancer of the cervix specifically. That's all it does. It's just a cervical cancer screening test. We like to start Pap screening at age 21, regardless of sexual activity. So even if somebody hasn't become sexually active, 21 is a good time to come in and see GYN. So we can start Pap screening by itself. Along with that, we're going to ascertain, any needs, medical needs, menstrual needs, fertility concerns, anything at all. So I think with just like a general OB/GYN in your community is probably a wonderful place to start for them to get them kind of plugged in and get them worked up. Yes. And one thing I always like to say to my bleeding disorders patients and all my patients is really, if you have a problem that bothers you, I don't care what the problem is. Like, it's worth bringing up. Like, some people are very reluctant to disclose information, or feel like it's not a big deal. Like, oh, everybody in my family has heavy periods. Oh, all the women in my family have, crazy bleeding. That may well be true, but that is not typical. And that is definitely something that we can treat. It's like, you don't have to be living with any symptom that you find disruptive to your lifestyle or undesirable. We can always work on that. And there's many, many ways to manage all the different problems that I mentioned today: surgical, medical, expectant, lots of different things to do. So broaching the subject is always the first place to start. Yes, ma'am. So if they don't know their family history, you mean? Right. So I'm going to discover that. So we're going to, once I'm talking to that young patient, even if she doesn't know her family history or disclose, if her periods are heavy and bothersome, we're going to work that up. Like, if somebody tells me I bleed longer than 7 days, I'm saturating a pad, every hour, it's really annoying. My basic workup is a CBC, right? A complete blood count. That's assessing for anemia. I'm going to look at her TSH. That's that thyroid stimulating hormone that we talked about. This is like basic, like regular, not expensive. All insurance will pay for this kind of like middle of the road type of blood work. Whether or not I actually seek out a bleeding disorder is going to depend probably on some other symptoms, like easy bruising, bleeding with brushing teeth, surgical bleeding, things of that nature. If everything else is like, we don't find anything, like she's got a structurally normal uterus on exam, I don't feel any big bulky masses, everything looks normal, she's not anemic, her thyroid is stone cold normal, then we can start looking at some less common, I would say, things like doing like not factor levels, but coagulation studies and von Willebrand factor assays, looking for specific bleeding disorders. But I would encourage you all, like, if you have daughters and sons and whoever your progeny are, and they're emerging adults and they're coming into their own and starting to take care of their own health, empower them and encourage them to write it down if you need to, like, come with them if they're comfortable. And having that information is very helpful because it cuts out some time and workup. It helps us get to the correct diagnosis, which will help us get more quickly to the correct treatment. So. That's most of my 21-year-olds, actually. So my approach, usually, I give them like things to read and websites. There's a wonderful website. It's called bedsider.org. I don't know if y'all want to jot that down. Bedsider. It's done through the NIH, and it's a beautifully done website. It's got testimonials, like peer group, reports about all the different medications we offer. And the thing is, they don't have to decide right that minute. Like I can say, okay, your periods are heavy. Here's some hormonal options. Here's some non-hormonal options. We can watch and wait, and you can do menstrual calendars. You can do any of these things. Like you're not anemic. We have some time. Like if somebody's anemic, obviously that's going to change my counseling a little bit. Like, hey, we need to treat your anemia. I think you should start some sort of medicine. Here are all the medicines you can consider. You don't have to decide today. Here's the risk and benefits, and you let me know. We'll make a follow-up visit, maybe 6 to 8 weeks. We'll reconvene and we'll discuss it again. You bring me your questions, you read what I've given you, and it's a stepwise approach, especially when people are young, 21. Sometimes it takes a few visits, first of all, just to establish trust. Like they don't know me, they're like, whatever. So sometimes it just takes that much time to kind of complete the therapeutic relationship bond. But yeah, we just give them options and time. Like nothing has to be done right that day. Mm-hmm. 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 Oh, wow. Mm-hmm. Mm-hmm. It is. It absolutely is. Yeah. Yeah. And that's the whole point of meetings like this and conferences and talks, because we want to disseminate. I want you guys to go out and widely share with your friends, your communities. We can treat these things like usually at very low cost and very low side effects. And you don't have to be living with, disruptive symptoms of any kind, really, especially of a pelvic nature. I feel like historically, unfortunately, a lot of times women's health concerns, we all are very well aware of these things. We're kind of like brushed to the side, like, oh, it's your curse, it's your time of the month, it's the, whatever you want to say, but that life does not have to be this way. It's okay. Mm-hmm. Mm-hmm. Right. Right. And people, there's a misconception out there that it's normal. Like your periods are supposed to be miserable and terrible, and you're supposed to be cramped up and in a ball in the bed, but that's really not the case. Like a menses should be, I always tell patients 3 to 5 days of very manageable bleeding. You should be able to do every single solitary thing that you did the day before. Like it should not be that disruptive. And if it is, and that's when we know we need to go and look for other types of issues and other types of problems, because you really should be able to live well with a regular old period. Like it should not really be that disruptive. Mm-hmm. Right. That's wonderful. That's the way to do it. And I think the internet offers us a wonderful opportunity. Like now we can communicate with everybody. You know what I mean? So if you have an internet connection or a smartphone, which most young people, in our part of the world have access to, it's fairly easy to get that information out there and to make sure people know that they have resources and assistance available. Okay.
I don't have a question, I just have a comment. I work at a hemophilia treatment center, and about 10 years ago, we started a young women's clinic. Actually, we kind of modeled off of Emory's. But it's amazing to, I've worked for the treatment center for 27 years, and it's amazing to see how the difference between the moms that are now able to have their daughters in at 12, and gynecology is right there with us in the same clinic. And okay, does this work for you? And they've diagnosed so many, our gynecologists have diagnosed so many girls with platelet disorder and VWD. But it doesn't have to be, they don't have to fear because their moms grew up fearing their periods. And then, we've even had moms that say, a 16-year-old, well, she doesn't she has horrible periods. Let's give her a hysterectomy. No,
No.
you don't have to do
Yeah,
that.
I've heard that.
It is.
recently.
It's not. It's more. I mean, it's not.
Mhm.
You know, that uncommon for these moms to say, you know, let's just get rid of it.
Mhm.
And it's like, well, you're taking a decision away from a girl that she doesn't want to have kids. Well, how does she know that at 14, 15 years old?
Exactly. So yes.
Yeah. And
Hysterectomy
so,
is
but
rarely
if,
appropriate.
yeah. And if you
get
get, but I've seen such an amazing turnaround just with women with bleeding disorders and girls with bleeding disorders, how much more people are. It's not just, it's just your period. That's all it is.
right.
It's just your cross you have to bear.
Right.
But it doesn't
Exactly.
have to be that way. And, you know, girls come in, oh, I'm bleeding for a month and a half. And our doctors are like, you don't have to do that.
No.
We can do
Yeah.
things about that. And that's
Exactly.
what is exciting to see that. And since we started the Young Women's Clinic, it's everyone, all the players are at the table. So the
It's
gynecology
amazing.
and
It's
the
amazing.
patient.
And it's
Yeah.
normalizing, right?
Yeah.
It's like, it's not intimidating. We're
Right.
not going to do like, and I'll say this too, like a lot of our young girls, when we had our women's clinic in pediatrics established, were very nervous to come to clinic because they assumed that I was going to do a pelvic exam. And I can tell you, I don't think have never, have I? No, I haven't done any pelvic exams in pediatric clinic. That's very rarely necessary. So I think a lot of it is, like you said, dispelling myths and providing comfort and normalization. Like half of the world are women, half of the world have periods. So this is something we all need to be talking about, and it's okay. So
And the changing of terminology of so many moms, I don't want her on birth control. Well, it's hormone therapy. Hormone control,
Yeah.
because you take that birth control word out of it,
it's
because
definitely stigma associated.
I mean,
with
if my daughter's 32 and has a child, but it's like, if I would have said, you know, at 14, 15, somebody wanted to put her on birth control pills, I'd be like,
right.
it's just the thought of that.
It's the
like you're
stigma associated
giving
with it,
permission to
definitely.
something that you really are not giving them permission, but it's just that terminology. And it's exciting to see over the last 25 years, just the advances in the treatment and the way people and the providers treat women and young girls with.
Yes, I agree.
issues.
Thank you for that comment.
Thank you. All right. I think that was our last question for the day. Thank you,
all
Dr.
for your
Woods.
attention. I appreciate it.
Thank you. Thank you. I'm way up here. Thank you all for attending. We do have evaluation. So if you, these are lovely pictures. Dr. Woods, for your family. If you, that was lovely. Oh, here. This is so sweet. Oh, so lovely. Thank you all for attending, both in person. This was also streamed virtually. Thank you to our virtual participants, and thank you, Dr. Woods. We might have to scuffle out of this room for our next speaker, but Dr. Woods is available. So if you catch her in the hallway and you have any extra questions, feel free to let her know. But thank you so much for attending.